Hello and welcome to clinicalpath.com. Today's lecture is on interstitial lung disease. Interstitial lung disease is an umbrella term that is used to describe any process that scars the lung through inflammation and fibrosis that ultimately ends up giving a diffusion defect in the lung. So when we're talking about lung, we break it into bronchial and alveolar. This is therefore an alveolar or restrictive disease. So when we form a mental image here, which we see of the alveolus, we think of our alveolus wall as basically being our type 1 pneumocyte, our type 2 pneumocyte, which creates the surfactant, and the endothelial cell with this very, very thin epithelial endothelial barrier. So when you're forming the image of inflammation and fibrosis, we're putting it in the alveolar septum. Here's a fibroblast here, and so we're going to start to see all this proliferation of fibrosis, which is ultimately going to end up between that epithelial and endothelial cell. And so you think of this as being a scarring inflammatory disease that's going to give us really, really thick alveolar walls, and that's what's going to create that diffusion barrier. So that defines all of our interstitial lung diseases. When we talk about how to classify them, they basically break into the occupational, which is going to be our diseases of coal workers' disease, silicosis, asbestosis, and then much less commonly, berylliosis. The next big group we have is the connective tissue diseases. So this is rheumatoid arthritis, lupus, Sjogren's, all of that family of connective tissue diseases. Many medications can also cause lung fibrosis. Obviously, we're familiar with the chemotherapeutic drugs of methotrexate and bleomycin, but amiodarone for heart disease and nitrofurantoin in bladder infections also are known to cause this. So when we talk about this group, this is the group in which we know the causes because the history is really straightforward in identifying them. Other diseases that we think of in causing interstitial are our hypersensitivity pneumonitis. Second big group in here is going to be sarcoidosis. So these then become our granulomatous diseases. And then if none of those causes are known, we get to actually what is the most common cause of all of these, which is going to be our idiopathic. So that's going to be idiopathic pulmonary fibrosis. Remember that these diseases all start with shortness of breath, so our critical differential is going to be between chronic obstructive pulmonary disease and congestive heart failure. So as we talk about how you're going to do that, let's just eliminate congestive heart failure. You can get a BNP test, you can do an ejection fraction. There's really good testing for differentiating those two. Within the lung, however, we always want to think about our COPD, which is an obstructive disease, versus interstitial lung disease, which is going to be a restrictive disease. So they both present with shortness of breath. Note that COPD is going to present with a productive cough, but interstitial lung disease is going to be a non-productive loss because it's in the alveolar wall with inflammation and fibrosis. When we talk about crackles, interstitial lung disease has a very specific crackle pattern, whereas we don't think of COPD as having crackles, we think of it as having wheezing or rhonchi. So no wheezing in interstitial lung disease, but yes, we see it in COPD. And the last, finger clubbing, is seen in about half of the cases of interstitial lung disease, but it is not a feature of COPD. When we come to pulmonary function testing, this is just very, very basic, straightforward stuff. FEV1 over FVC is greater than 80% in interstitial lung disease, but less than 80% in chronic obstructive pulmonary disease. Interstitial lung disease has a decrease in forced vital capacity or total lung capacity, but this is preserved in chronic obstructive pulmonary disease. That thick fibrosis in the alveolar wall is going to give us an impairment of diffusion but that is not affected in COPD. And lastly, on imaging, remember this is going to be abnormal. In interstitial lung disease, we're going to see on chest x-ray reticulonodular pattern of disease. On CT, that is going to be ground glass. But really, COPD doesn't have specific characteristic imaging abnormalities. So this is a pretty fundamental difference in medicine between restrictive and obstructive diseases, and that should be clear in your mind. So all interstitial lung diseases, all of them, have these same common features. So after that, we have to go into differential coming from other basics than clinical presentation. When we talk about what those are going to be, they're all going to present with shortness of breath and a non-productive cough. That doesn't discriminate amongst the interstitial lung diseases. When we come to the physical exam, we're going to be seeing crackles, and there are some clinical difference in the types of crackles that we see, and they're both going to present with clubbing. And when we come to pulmonary function testing, remember this is going to break into our spirometry, which is going to preserve our FEV1 at greater than 80%, but it's going to show a decrease in forced vital capacity. But remember, when we talk about our diffusion, all of them are going to have a diffusion defect. We're going to be talking about other tests in here. We have to do serology for all of those connective tissue diseases. And then the cornerstone of diagnosis is going to be our high-resolution CT scan, because that's going to show ground glass, which is the hallmark of fibrosis on the CT scan. And with evolution of the disease, it all goes to honeycomb lung. So those are all common to all of the diseases, and we need other parameters to differentiate amongst the interstitial lung diseases etiologies. So let's just pause for a sec here and talk about what the lab tests would be, because what we have here is a listing of all the connective tissue diseases that you need to have in medical school, and then what the serologic test that's the cornerstone of its diagnosis. So go scleroderma, that's going to be anti-SCL70. Rheumatoid arthritis is going to have two. It's going to have anti-CCP, that's the one everyone uses most specifically, but you'll also see rheumatoid factor is still included, mostly for historical purposes. Lupus, remember the most sensitive test for lupus is anti-nuclear antibodies. If that's negative, you probably don't have the disease, but there's a whole host of other tests in this, isn't there? Dermatomyositis, polymyositis, this is our anti-Jo1 synthetase. But if there's involvement of the muscle, we're also going to see an increase in creatine kinase. Sjogren's syndrome is going to be anti-SSA or Rho and anti-SSB or La. And then mixed connective tissue diseases that presents with nonspecific joint and skin and other changes, usually over time ending up as being lupus or scleroderma. This is going to be our anti-ribonuclear protein antibodies, and the one that we usually start with is anti-U1. So that's a really basic table of serology, and one that you really want to practice and make sure you've mastered. But remember, at the end of the day, high-resolution CT scan is going to be the absolute characteristic test for all of these. All of them present with fibrosis, which on CT is called ground glass. And remember, as the disease evolves, it evolves into a honeycomb pattern. But the pattern and distribution of this is different amongst the different types of interstitial lung diseases, and so we'll be discussing the different patterns that we see in different parts of the lung field as we do the diseases. Okay, well, let's start with our occupational lung diseases, or the so-called pneumoconioses. And note that all of these are inorganic. Starting with coal workers' pneumoconiosis, this used to be extremely common in America, especially for all of the peoples living in the Appalachian, where it was a fundamentally important part of their industry. But the thing about coal is it is actually the least fibrogenic of all of the inorganics. And so what that means then is you don't see coal workers' disease unless there's some other associated problem. So that means that they typically have to be cigarette smoking, or they have to be working with a coal that has a high content of silica before they're going to get significant underlying pathology. The epidemiology, this typically affects about 10% of all the workers. Now, most workers don't really work at the coal face. If you are full-time on the face, you'll see at about 50% of the workers will be involved at about 20 years. But most people don't work full-time at the face all their careers. So when we talk about the pathophysiology of this disease, it really breaks into two patterns. The first is basically your simple coal workers disease. CWP, coal workers pneumoconiosis. And this is completely asymptomatic. And what it really is the coal dust goes down to the levels of the respiratory bronchiole, and there it does a little bit of fibrosis. And mostly this is going to be subclinical. You can see this coal here in the picture. Here we see these areas of black pigment, and that's actually the coal dust as it's been phagocytized in macrophages. So we wouldn't really worry much about coal workers' disease, except that 10% of patients develop massive pulmonary fibrosis. So that's called complicated coal workers' pneumoconiosis, and no one can predict which of the 10% are going to go on to massive pulmonary fibrosis, but obviously that is life-threatening, and therefore you have to monitor your workers to see if you can see those changes. And if you get massive pulmonary fibrosis, now you're going to go on to respiratory failure and cold pulmonary, so that's truly someone that has to get off the coal face. Silicosis is anything that exposes the lung to crystalline sulfur dioxide. This is also called silica. And you can see this anytime you're working around processing of rock or stone. This is absolutely the most common of the pneumoconiosis in the world. And there's some surprising places that you work with rock and stone, so you've got to sort of take a moment to think what they are. So obviously if you're doing mining, we can all figure that out. But some of the other subtle things are things like grinding. So if you're doing gravestones, you're grinding granite, and that's going to expose you to silica. Remember, the glass is just basically melted sand, which is silica. So anyone working in glass industry is exposed. But probably the commonest one we see in America is working with cement. Anyone working with that cement concrete powder is really exposed to it. The pathophysiology of silicosis is different from that of coal, which is not terribly fibrogenic. Silica is toxic to macrophages. So the first association we should have with that is that macrophages do growth factors, and so that becomes the basis of the fibrosis and the TGF-beta disease from the abnormal macrophage. The other thing that we see is decreased immunity. So the single most important thing to know about silicosis is you've really got to monitor your patients for tuberculosis because they're extremely vulnerable. And then, of course, the other thing they can do is they can get abnormal immune function, and so there's an increase of connective tissue diseases like rheumatoid arthritis and lupus, as well as a risk of cancer. And when we take a look at the pathology of this disease, the pathology of this disease is seen right here. We can see that the macrophages phagocytize the silica. If we could polarize this, we could see the silica crystals in those, and then the response is this discrete fibrous nodule, which we typically see in the upper lungs. So when we talk about the pathology of this, it really shapes up pretty similarly to our coal. We can have our simple disease, which is just the fibrosis, often associated with an eggshell calcification in the hilum. So if we were to take a look at the chest x-ray, which I'm drawing up here in the upper page, you're going to see these calcified hilar lymph nodes from the degenerative changes from the silica. But of course, the real worry is that you can also get complicated. And when we have complicated, then complicated disease is going to give us massive pulmonary fibrosis. And massive pulmonary fibrosis is going to lead to cor pulmonale and respiratory failure. Asbestos is the third of our occupational lung diseases, and this is just a generic term that refers to any of the silicates that form fibers. So that's how you should think of this disease. It's the fiber nature of the silicate that makes it asbestos. And this used to be very, very widely used. So it has tremendous anti-thermal effects. And so it was widely used anywhere that you wanted to control heat. And so we find it in anything that is old. So when we have old buildings, when we have old ships, this tends to be the major exposure that we have now, is when we are decommissioning. It's not used in construction anymore. It's been replaced by synthetic fibers. So unless you go to the third world, it's got to be an old structure to find it. The only place that we're currently presently using it is in brake linings. So the only group in America that's really currently exposed to it is going to be in auto body shops. If you see a case, then it's either got to be an immigrant, it's got to be someone with decommissioning, or it's got to be someone working in an auto body shop. So the pathophysiology is one of inhaling the fibers. And when we inhale the fibers, they go down to the level of the respiratory bronchiole. So a quick review of the bronchial tree, right? There's our laryngotracheal main stem bronchi tree. Then we come to our bronchi. Remember, they have cartilage and glands. Then we come down to our bronchioles. And then we come down to our terminal respiratory unit, which is going to have our respiratory bronchioles and then our alveoli and our alveolar ducts. So when we're aspirating the fibers, they're coming down here to the level of the respiratory bronchiole. And now we see that there are two different kinds of fibers. The first type of fiber is what's called the chrysotile fiber. And it has a curvy shape, which is why it's also called serpentine, meaning snake-like. And this tends to be a long fiber that easily fragments. And so the macrophage can phagocytose these and break these down, and so these get cleared basically in a matter of 1 to 2 weeks. So as the fibrosis from this disease comes from intensity and duration of exposure, these aren't the dangerous fibers. The dangerous fibers are the amphibole fibers. These are the least common. They only make up about 10% of most of the exposure that people see, but these are short and straight. And these don't get broken down very readily, typically taking something like more than 1 year to clear. So these are the dangerous ones that give you long time exposure to it. Now the danger of all these fibers is these fibers absorb metals. They have metals as part of the fiber and then they absorb them in the body. When in fact they're phagocytized by the macrophage, they get coated in ferritin. And that becomes then not only diagnostic, but the pathology. So here we can see a lung field in the picture, and you can see this is a Prussian blue stain, which is showing the straight fiber coated with the iron. And of course, iron is dangerous because of the Fenton reaction, which is going to give us free radicals of the hydroxyl group, which are extremely damaging to the body. So when you think about this disease, you're thinking of the short amphibole fibers, which absorb metals. The metals create Fenton reaction, and the Fenton reaction creates the free radical damage. So what then are the disease associations with this production of all the free radical damage? Well, the first is we get fibrosis starting from the respiratory bronchiole and extending out into the surrounding alveolar walls. And the term for this is asbestosis. So when you use the term asbestosis, you're really referring to the diffuse pulmonary fibrosis. This doesn't tend to be life-threatening, but we find that it's mostly basal, meaning in the lower lungs, and it's subpleural. And this is going to be very, very similar to idiopathic pulmonary fibrosis, so that forms a major differential. The second disease association is we get fibrosis of the pleura, and that forms our pleural plaques. And the pleural plaques tend to be thickening of the parietal pleura. So if we are going to draw a lung here, this is going to be our visceral pleura. The fibrosis tends to be in the parietal pleura. So when you take a look at an X-ray, you're going to see these dense areas of fibrosis lining the lung, and this is what they look like here in the picture. They're these dense nodules with these sharp edges, and they're thick benign fibrosis. These are not precursors to mesothelioma, but clinically they may be associated with effusions, so they can be symptomatic, but not because they're going on to form a malignancy. The third disease association is going to be with carcinoma. And this is just the regular type of carcinoma. It's highly associated with cigarette smoking. So yes, there is a small bump in non-smokers, but it's smokers that really have the problem because, of course, these fibers absorb, and they absorb the carcinogens from the cigarette smoke. And then the last of our associations is going to be our mesothelioma, which is a highly aggressive malignancy of the mesothelial layer, and this is the most specific association, and it is not smoking related, and it tends to be highly malignant. The last of our occupational diseases is berylliosis. This is a bit of a surprise because you see it in high-tech manufacturing. So you don't really think of someone working in electronics or working in the nuclear industry in their nice clean suits. You don't really think of these people being exposed to it, so it's not going to be at the top of the list of things that you do. Other diseases include things like people working with ceramics or metal alloys. Boy, you just think of those as clean industries. But the important part of the disease is that the beryllium induces a granulomatous response. And so that granulomatous response from the macrophages that phagocytize it give a clinical picture that's very similar to sarcoidosis. So you're going to see an increase in the hilar lymph nodes, and you're also going to see that pulmonary interstitial fibrosis. So when these patients present, you're obviously going to first think that it's going to be sarcoidosis, and it's only when they don't respond to treatment that you're going to go looking for other causes, and then you're going to recognize the occupational association, which probably won't occur to you first off unless you're working in that industry. Okay, so from our 4 inorganics, we now come to the organic interstitial pneumonidities. Another name for this is extrinsic allergic alveolitis. And boy, that's just not a very good name. Okay, I get that it's extrinsic because it's outside of the body. But you know, usually when we say allergic, we usually think of that as being an IgE type of disease, and this is not. This is antibodies that are IgG in type. And then lastly, we think of this as being an alveolitis, but in fact the exposure is in the bronchial tree. So while you'll see extrinsic allergic alveolitis, boy, that's just not a good name and doesn't explain the pathology well. This is really a diseases that are all immunologically related. So it's immunologically induced. It's going to be an inflammatory disease, and it's in response to an inhaled antigen. And most of these antigens are going to be organic dusts. When we go and take a look at what those are, they really classify, as you can see, into these 3 groups: microorganisms, proteins, and then least common are the low molecular weight chemicals. And boy, it's a long, long list. So when you say, well, which are the ones I want? Let's go to the ones that are most common in America. So one of the really common ones you're going to see is farmer's lung, and these are our thermophilic actinomyces. And these are the ones that we're going to see in hay and poorly stored grains and silage. Hot tub lung is actually pretty common for us, which is associated with our Mycobacterium avium intracellulare complex. And we not only see this in hot tubs, but we also see this in humidifiers. So anyone that's working in that damp environment can see this. And then the last group that we're going to see is air conditioner lungs, and boy, there are many, many different types of organisms that grow in that humid. So when you're saying to yourself, which are the microorganism-related diseases, these are the three that you're going to see in practice. When we talk about proteins, these are mostly going to come from animals, and obviously there are lots of animals involved here. But by far the commonest is going to be bird fancier's lung, and so anyone that has things like pigeons or parakeets or budgies or canaries, these antigens come off the feathers and the feces, and then these patients get the inflammatory response. Low molecular weight chemicals, these are mostly our isocyanates, and they're widely used in industry. So you're going to see it anytime you see someone working with polyurethane foam, people that are working with adhesives, and people that are working with paints. Those are all sources of isocyanates. So these antigens then cause this pathophysiology. The first thing that all of these things have in common is they have a small size. Most of these are around 1 micrometer. And remember, to get all the way to the alveolus, you've got to be less than 5 micrometers. So that size is really important. So it goes down to the level of the alveolus, where it's going to be phagocytized by the macrophages. Now, the alveolus itself doesn't have lymphatics. Those macrophages have to get to the lymphatic system, which is starting in the respiratory bronchiole. And from that respiratory bronchiole, then, we get the formation of our Th2 response, which is going to form IgG and a little IgM and A, but not IgE. This is not the sort of classic allergic immunity that we're thinking about. Then once you get the re-exposure, now we're talking about antigen-antibody complexes, which are occurring at the level of the lung. And now we're going to see a classic type 3 hypersensitivity, because antigen-antibody complexes are going to attract inflammatory cells. And so now we have the inflammation, and now we've set up our response. If it carries on over any length of time, there's our acute exposure, but over time, we're going to see a granulomatous response. And this granulomatous response is going to be at the level of the bronchiole. And now we can see that if we're talking about granuloma formation, this now becomes a type 1 hypersensitivity. So starts as a classic type 3 antigen antibody production, and then over time with re-exposure develops a type 1 granulomatous response. And then if the exposure goes on chronically at low levels for a long period of time, then it goes on to form the fibrosis. Well, so who walks in the door? What's the clinical pathologic correlation? Well, you can see that we've described 3 pathologies. We've described the acute pathology, antigen-antibody complex. So that's obviously going to occur at the level of neutrophils. And so no surprise, once you get exposed to the bird feathers or the moldy hay, this is going to be a disease of ours. And the symptoms are going to be acute inflammatory, so these are going to be our flu-like symptoms. So that's going to be things like fever, cough. And on physical exam, you're really not going to have much to find. It's acute, and if you took an x-ray, you really wouldn't see anything. But if the exposure carries on, we're going to see a change from a type 3 antigen antibody acute inflammatory response. Now we're going to form granulomas. So then this is going to be really a disease of days to weeks, which is the time frame of macrophages. And now we're starting to fill the lung up with more diffuse processes, and now your patients are going to start to develop dyspnea. And if we did imaging, now we're going to start to see the granulomas changes. So we're going to see development of nodules throughout the lung. We're going to start seeing ground glass opacities of the interstitial fibrosis, and we're going to see this uniformly throughout the lung fields. Now, clinically, acute and subacute can be very difficult to separate because you're talking about a disease of hours to days and a disease of days to weeks. So these are often lumped together. Even though they're pathologically different, clinically they're often lumped together. But that's really different than when we get into chronic, right? Because when we get into chronic, this is our low-grade, long-term exposure. And so this is going to be a very different pathology because this is now the pathology of fibrosis. So this is going to be a disease of months to years. When we talk about the symptoms now, these are going to be really different, right? These are not only going to be our dyspnea, this is going to be long-term hypoxic changes of fatigue and weight loss. So that's going to be a much more worrisome finding. When we do physical exam now, we can find the so-called crackles that you see with pulmonary fibrosis, and these crackles are typically called pops and squeaks. Now, I've personally not worked in this area, so I can only tell you that's what people report, is it's a distinctive pattern. And as well, once we start getting these systemic changes, you might see clubbing of the fingers. And now when we come and take a look at our imaging, we're not only going to see the nodules and the ground glass of the acute disease, but we're also going to see progression of disease to our honeycombing. So when you think about these organic exposures, it isn't a single story, is it? It's a story of first exposure forming antibodies, and these are IgG, and then re-exposure acute inflammatory, ongoing exposure granuloma, but low-grade many-year exposure leads to fibrosis and honeycombing and systemic effects. So how are we going to make the diagnosis? Well, remember, we've got two patterns of disease we got to think about diagnosing. The first is going to be our acute, and this is going to be our flu-like illness, and frankly, you probably won't recognize it until you've seen that it's repeated many times, so you go, well, that can't be a virus infection. And when we talk about the chronic fibrosis, this is going to look like every other interstitial lung disease going on to fibrosis and honeycombing. So at the end of the day, the key to this is you have to recognize the antigen exposure. So if you've got someone with a hobby farm and they're always tossing the hay, or you've got someone that races pigeons, that's the single most important thing. Now, other things that you can do, for example, you could do bronchial alveolar lavage. You can go down and literally wash the fluid out in the lung, and then you'd say, well, what kind of cells would you see? Well, this is chronic inflammatory, so you're going to see the lymphocytes as part of the inflammatory process. And so that's going to rule out other acute and other inflammatory diseases. If you went to do a lung biopsy, obviously then what you're going to be looking for is a granuloma. So cell type and tissue type can be very helpful. But at the end of the day, diagnosis is made by high-resolution CT scan. And this is going to show our centrilobular nodules, because remember, that's where we're getting the exposure to the antigen in the respiratory bronchiole. Remember, we're going to have multiple ground glass exposure, because ground glass is the CT expression of fibrosis. And then throughout the lung, it is uniform throughout the lung. So that's going to be the single best way of finding it. And obviously treatment is just what you think. You've got to stop having them exposed to the antigen, and acute inflammatory processes can be managed with steroids. Well, sarcoid disease is a pretty common disease, extraordinarily heavily tested. So remember, this is a systemic granulomatous disease of unknown cause. So that's pretty unhelpful, isn't it? But there it is. Epidemiology, this is the disease of young people. So this is ages 20 to 40. So your classic patient is going to be in the 30. It is increased in African Americans. And I know that everyone says it's commoner in females, and that may be true, but when you actually go look at the data, not as good as you'd think. Well, pathology depends which of the organs that get affected. And you can see almost everybody gets affected, lung and hilar lymph nodes. So when we talk about what do we see in the lungs, we're going to see granulomas in the lungs. And remember, it's going to be peribronchial because that's where your lymphatics are. And then from that peribronchial location, it goes on to the alveolar fibrosis. When we talk about the lymph nodes, this is especially going to be in the mediastinum and in the perihilar region. And if you look in these nodes, they're going to have granulomas, so that becomes a really great target for our biopsy. Liver, nothing special here, just the granulomas of the disease. In the skin, we're going to see two different patterns of disease. We can see erythema nodosum, but you can also see granulomas in the skin as well. Eyes develop an anterior uveitis, but it turns out that's really ethnic developed. The highest association is actually in the Japanese for reasons that aren't clear, but eyes are involved up to as much as 2/3 of patients. But the most magical complication is hyperglycemia, which is seen in about 10% of patients. And the reason for that is, remember that macrophages are really high in 1-alpha hydroxylase. And 1-alpha hydroxylase, remember, creates cholecalciferol. So these patients have high levels of vitamin D3, which affects the gut. And the gut now is going to absorb calcium, and so they present with hypercalcemia, which is our classic bone pain, vague abdominal complaints, mental changes, kidney stones. Moans, bones, groans, stones with psychic overtones. So, when our patients present, they're either going to present with our respiratory symptoms, which is going to be shortness of breath and non-productive cough, maybe some chest pain, or they're going to present with the systemic changes, which obviously could be any other organ, but also includes the cytokine B symptoms of fever, weight loss, and fatigue. And when you go investigate that, one of the classic things you're going to see, especially if they have shortness of breath and cough, is you're going to do a chest x-ray. And this is a really great picture of your standard chest x-ray. And this is what is called the 1, 2, 3 pattern. Because you can see up here, I'm up here, I have a prominent group of lymph nodes from the mediastinal group, and then I have my right hilum and my left hilum. And there's nothing special about this group up here. It just happens to be on chest x-ray. That's exposed better by the nature of the anatomy, and so they're more easily seen than the ones over here on the left side. So that classic pattern of 1, 2, 3 is quite recognizable by radiologists as the lymphadenopathy of sarcoidosis. So diagnosis, first and foremost, is going to be our chest x-ray, where we're going to see both the lung and the lymph node changes. In the lab, you can see there's an increase in the ACE enzyme. Turns out that's pretty nonspecific, so you see it in all the medical student texts, but it's hard to use. But at the end of the day, you have to confirm with a biopsy showing that you've got a granuloma. So tissue diagnosis is the absolute essence of diagnosis. Sarcoidosis is actually generally a benign disease. Over 2/3 of your patients are actually going to be completely benign and self-limited, and they will get well even if you have no treatment at all. The problem is the remaining 30%. Another 20% do go on to get damage, and the damage particularly is in the lungs and in the eyes. So those are the vulnerable organs if you're going to get it. And then 10% are going to go on to get pulmonary fibrosis and that obviously is life-threatening. And treatment is just what you think. You're going to key on steroids and our anti-TNF biologics. The last of our diseases for our interstitial is the unknown category of idiopathic pulmonary fibrosis. So this is a clinical pathologic correlation because obviously it is a disease of exclusion. You've got to rule out all the known causes of interstitial lung diseases. And that's going to be any disease that you've ruled out the other causes that causes progressive fibrosis. And that has to eventually lead to a diffusion defect and respiratory failure. And this has become really urgent because there's been a whole new generation of antifibrotics. They've actually shown they can interrupt the natural history of the disease. And so these antifibrotics, the pirfenidone and the nintedanib, these have actually changed the natural history. So idiopathic pulmonary fibrosis has gone from a disease in which we could do nothing, and so missing the diagnosis had less consequences, to a disease where we're starting to get effective therapies. This is a disease that increases with age. If you have a patient that has a non-productive or dry cough, and they are over 70 years of age, and they have a negative chest x-ray, that's going to be idiopathic pulmonary fibrosis, by far and away the commonest cause. So this is a disease that most of us are going to see in our practice. And it's a disease in which males are more commonly affected than females, so your typical patient's going to be our 70-year-old male. Pathophysiology is starting to be better understood now. First of all, we have to start with the appropriate patient. So we know that there are patients with well-described genetic predispositions. There have been well-described environmental situations that are significant, and then other is increasing age. And these people are predisposed to, when there is injury, to the type 2 pneumocyte. That's thought to be the key cell that's involved with the injury. It's your precursor cell. It can go on and replace lost type 1 cells. So this is the key cell that when we get that injury, then we go on to get repair of that injury with the usual cytokines of fibrosis. So we're talking about our TGF-beta and our platelet-derived growth factors. So those, as always, are the key guys in fibrosis. And with them, of course, then we get the proliferation of myofibroblasts, just like every other chronic systemic inflammatory bowel disease. And then that's going to go on and give us our progressive fibrosis and the disease. So as you follow this disease through your career, trying to recognize what is that injury to the type 2 pneumocyte is going to be the key to understanding etiology, because right now that simply isn't known. When we talk about the pathology, the fibrosis that we're seeing is going to be both lobes, so it's bilateral. It's in the bases of the lung, and it tends to be peripheral. And so when you take a look at what that looks like, remember, it's a progressive disease, so it's always going to be showing the most advanced pattern of the fibrosis, which is our honeycombing. Diagnosis, well, it's going to be all the usual things for interstitial lung disease. So the patients are going to present with shortness of breath, a non-productive cough that's gone on chronically, say more than 8 weeks, and on physical exam, you're going to hear the crackles and the clubbing. But remember, this is a diagnosis of exclusion. So when we come back to the known causes of interstitial lung disease, we're right back to the beginning of the lecture, right? Because our first group was going to be our occupational. So that's going to be our coal, our silica, our asbestos, and our beryllium. We're going to be talking about our connective tissue diseases. So this is going to be our scleroderma, rheumatoid arthritis, lupus, Sjogren's, dermatomyositis, polymyositis, and mixed connective tissue diseases. And so this is where you've got to be able to understand the serology testings we're going to order to rule them out. The next big group which we've covered is going to be our hypersensitivity. And so this is going to be our microorganisms, our antigens, and then our industrial exposures. And then the last group that you don't want to miss is going to be our medications. Because if your patient's on amiodarone, or they're a cancer patient receiving chemotherapy, those are really likely causes of the disease. So you're going to start, as always, with your lung investigation. You're going to start with your pulmonary function testing. And obviously in our spirometry, we're going to see the usual expectation of an interstitial lung disease, which is going to be a normal FEV1 over FVC, so that's greater than 80%, and we're going to see a decrease in our forced vital capacity. If we did a diffusion study, we're going to see that there is a diffusion defect. But the key is going to be our high-resolution connective tissue scan. Because here we can see it's got to be in the base. Look at the shape of our heart here. You see that when we look at the aorta here, that's at about T5, and we don't see that here. So we've got to be below, somewhere below T7. So we know that we're in the base of the lung just by the anatomy of this image. And when we take a look at it, you see all these little cystic structures here. That's what honeycombing looks like on our CT scan. And you notice it's peripheral because it is subpleural. So the findings of bibasilar, peripheral, that is subpleural, honeycombing is absolutely characteristic of idiopathic pulmonary fibrosis. Now, if you were still unclear on it, you can go to biopsy. And biopsy, of course, is the hard pathology of what we see here. It consists of a patchy interstitial fibrosis. And if you were a pathologist saying, well, what about the fibrosis is unique about it, is that it varies in different areas. In the same biopsy, you can see an area of normal lung, and you can see an area of fibrosis. So pathologists get pretty good at recognizing this is a pattern, while not diagnostic, is quite consistent with idiopathic pulmonary fibrosis. Natural history, it's a pretty grim disease. The median survival of all comers is about 3 years. Obviously, this is going to change now that we have the antifibrotics. So all of your patients, once you've ruled out other causes and you're left with IPF, the treatment is going to be with our antifibrotics, and that's really early days, so that's going to change dramatically over time. So that brings us to the end of our discussion of interstitial lung diseases. And remember, this is going to be a number of areas that you really have to be good at. You have to recognize the general pattern of an interstitial disease. You've got to be able to do your occupational diseases of coal, silica, asbestos, and beryllium. You've got to be able to talk about your hypersensitivity and how these are an immune disease that has an acute, a subacute granulomatous, and then a chronic inflammatory. Got to be able to talk about sarcoidosis, very common disease and a granulomatous systemic disease. And then last is idiopathic pulmonary fibrosis, which is becoming much, much more important now that we have antifibrotic medications. So thank you for your attention. I'll see you next lecture.